Welcome to NephroTube Continuous Nephrology Education Lectures. This is my first lecture about membranous nephropathy. It is about presentation and the pathogenesis of membranous nephropathy, and it is just an introduction for the next two lectures about membranous nephropathy diagnosis and management. As an introduction, membranous nephropathy is a glomerular disease which presents with nephrotic syndrome in about 60 to 70% of the cases. Also, it presents with normal or mildly elevated blood pressure at presentation. The urine is usually of benign urinary sediment without red blood cell casts and of non-selective proteinuria. Membranous nephropathy is one of the common glomerular diseases presenting as nephrotic syndrome. So the most common presentation of membranous nephropathy is nephrotic syndrome. Regarding pathology, the main site of the deposits of membranous nephropathy is subepithelial, and the main type of the deposits are immunoglobulin and complement deposits. As any glomerulonephritis disorder, membranous nephropathy may be of a primary etiology or secondary etiology. Primary etiology is the most common. It is mainly in 2/3 of the cases. And secondary etiology of membranous nephropathy may be due to autoimmune diseases, malignancies, drugs and toxins, and some miscellaneous conditions. That was a very rapid introduction to my starting point of the presentation. My starting point of the presentation is the point at which you have a biopsy-proven diagnosis of membranous nephropathy. Suppose that you have a patient that presented to you with symptoms and signs and clinical presentation suggestive of glomerulonephritis. You did your lab investigations and the biopsy, and finally you have a biopsy-proven diagnosis of membranous nephropathy. So what is next? As any glomerulonephritis disorder, we have always at first to evaluate the presence of any secondary causes, as it is suggested by KDIGO guidelines, because the diagnosis of secondary cause and treating it increase the chances of the recovery of the glomerulonephritis. Secondary to that, we will treat according to the etiology, is it primary or secondary. And my next two presentations about membranous nephropathy, I will discuss in details how to evaluate secondary causes and how to treat membranous nephropathy. But now, before we go for how to evaluate secondary causes, we have to discuss first clinically applied pathophysiology of membranous nephropathy. Actually, there are three possible mechanisms for the formation of subepithelial deposits in membranous nephropathy. The first is the in situ immune complex formation, as there is a native antigen on the podocytes that is attacked by antibodies from the serum, and this will usually form the primary type of membranous nephropathy. Other two possible mechanisms for the formation of subepithelial deposits, that there is a circulating immune complex, circulating antigen antibody complex, that will be trapped and deposited on the podocytes. Third mechanism is that there is a non-native antigen that will be implanted on the podocytes, and then it will be attacked by circulating antibodies. The other two possible mechanisms of subepithelial deposit formation will mainly present by secondary membranous nephropathy. Regarding primary membranous nephropathy, what are the available or known type of the native podocyte antigen that may be attacked by circulating antibodies? Megaline is the animal model podocyte antigen. Neutral endopeptidase is another podocyte native antigen that mainly presented by congenital membranous nephropathy. And as I'm presenting lectures about adult nephrology, I will not go in depth through it. But the most important native podocyte antigen is the phospholipid receptor antibody that is responsible for about 70% of cases of primary membranous nephropathy. other newly discovered native podocyte antibodies rather than phospholipase E2 receptor antibody. The most important of them is the thrombospondin type 1 transmembrane protein expressed on podocyte that may also be attacked by circulating complexes and forming primary membranous nephropathy. And it is responsible for about 10% of primary membranous nephropathy with negative antiphospholipase E2 receptor antibody. To cut it short, what is the mechanism of primary membranous nephropathy? We have different points. The first, that there is a native antigen on the podocyte, which is mainly phospholipase E2 receptor antibody, which is mainly phospholipase E2 receptor antigen, PLAR2, and in some other conditions, in about 30%, it is another antigen other than phospholipase E2 receptor antibody antigen that I mentioned before. The second point is autoantibody, which is mainly of IgG type. Then there is a formation of subepithelial immune complexes that will activate T cell and membrane attacking complex. One important point is what is the subclass of IgG in primary membranous nephropathy. In primary membranous nephropathy, actually we call it now primary membranous nephropathy, not idiopathic membranous nephropathy, because we already know the native antigens on the podocytes. So in primary membranous nephropathy, the main subclass of IgG is IgG4. And in other secondary causes, IgG4 is not the main subclass of IgG deposits. And this is a very important point that we will use in our next lecture to differentiate between primary and secondary membranous nephropathy. And at the end of this pathway, there will be a podocyte injury and podocytosis and altered actin cytoskeleton with loss of slit diaphragm and degradation of the glomerular basement membrane with increasing permeability of the glomerular basement membrane and proteinuria. So the characteristics of primary membranous nephropathy pathogenesis are the presence of native antigen on the podocytes, which is mainly anti-PLAR, the activation of the humoral immunity, the presence of IgG4 subclass, and the formation of membrane attack complex. As the native antigen is the most important, I will talk in short about it, about antiphospholipase E2 receptor antibody. It was first described in 2009. In this study, they found that about 70% of cases with idiopathic primary membranous nephropathy had antiphospholipase E2 receptor antibody in their serum, while in secondary membranous nephropathy, other disease, and normal population, it was negative. One of the initial studies that studied phospholipase E2 receptor antigen and antibody in membranous nephropathy, they found that they examined antiphospholipase E2 receptor antibody in the serum and in the antigen. They found in 21 patients it was positive in biopsy and in the serum. In 3 patients, they found the antibodies circulating in the serum, but the stain was negative for the antibodies. In 8 patients, although they are diagnosed as primary membranous nephropathy, these 8 patients, although they had negative serum and biopsy proven phospholipase E2 receptor antibodies. In 10 patients, they had negative serum reactivity of phospholipase E2 receptor antibody, while the biopsy was positive. What I want to say in this point that, and this is my first clinical significant importance of antiphospholipase E2 receptor antibody, that the serum phospholipase E2 receptor autoantibodies test is a good positive but not good negative for is a good positive but not good negative marker for primary membranous nephropathy. So the presence of phospholipase E2 receptor antibodies is highly suggestive of the presence of primary membranous nephropathy, but their negativity doesn't exclude the presence of primary membranous nephropathy. Another important clinical significance of anti-PLAR that regarding anti-PLAR that their titers correlated strongly with clinical status. Patients with high antiphospholipase E2 receptor antibodies have more severe presentation with nephrotic syndrome, Also, low antiphospholipase titers associated with higher rate of spontaneous remission. Also, the decline in level of antiphospholipase A2 receptor antibody predicts the clinical response in immunosuppressive therapy, and that was documented in many trials that antiphospholipase A2 receptor antibodies predict long-term outcome in patients with primary membranous nephropathy. The question is, regarding antiphospholipase A2 receptor antibody, is it only related to primary membranous nephropathy? The answer is no. There are multiple small trials that showed that antiphospholipase A2 receptor antibody was discovered in membranous nephropathy secondary to other diseases. In this case, they found that membranous nephropathy secondary to lupus nephritis, hepatitis B virus, and carcinoma may have antiphospholipase receptor antibodies. And also some evidence present showed that it may be positive in some patients with membranous nephropathy secondary to sarcoidosis. So to collect the clinical significance of membranous nephropathy and antiphospholipase receptor antibody, presence of antiphospholipase 2 receptor antibody is highly suggestive for primary membranous nephropathy, but it doesn't exclude the coexistence of other secondary causes, especially if there is other highly suspicious, suspicions for the secondary membranous nephropathy. And this is what will I talk about in my next lecture, how to differentiate between primary and secondary membranous nephropathy. Regarding antiphospholipase A2 receptor antibody, it is a very important topic with more details, more evidence, more research. There is a lecture on NephroTube.com concentrating only on antiphospholipase A2 receptor antibody clinical application for membranous nephropathy. I recommend it to you to watch it, and I will try to record it and upload it on NephroTube YouTube channel. You will find the PowerPoint of this presentation on NephroTube.com, and the next lecture will be about the diagnosis of membranous nephropathy and how to differentiate between primary and secondary membranous nephropathy. See you later, and thank you.